Hello, everyone. Welcome to today's Phlebotomy Webinar, Transfusion Safety in 2022. Experience phlebotomists and electronic systems are key. This is Sierra Tollefson, an education specialist for Mayo Clinic Laboratories. Our presenter today is Dr. Paula Sandtrack, a consultant in transfusion medicine in the Department of Laboratory Medicine and Pathology at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions via the Q&A icon in Zoom. Please only use the chat function for any technical issues. Today's program is being recorded and will be posted to our website in a few weeks. And now I'll turn things over to our presenter.
All right. Welcome, everyone. I'm very glad to be here to talk about this. And I actually am also not only in transfusion medicine, but essentially the director of laboratory services, which is our phlebotomy team. So this is a good mix of sort of topics for me because I can, kind of mix two things together. They're very connected and very important from a patient safety perspective. All right. Just a minute. All right, I have no disclosures to make, no off-label usage. And what we're going to really try to do is talk about acute hemolytic transfusion reactions and how to prevent them. And it's important to know about what are the signs and symptoms and potential outcomes of these reactions. We're going to try and identify the most common causes and identify as well interventions to reduce and prevent such reactions, and also talk a bit about assessing the strength or likelihood of success for potential interventions. To me, that is sort of one of the sort of newer areas to be thinking about when you're talking about building processes and patient safety, is to sort of really say, what am I putting together and how strong is it going to be in terms of preventing what I'm trying to prevent? A little bit convoluted there, but it's really important to think your way through process design in order to get the right outcome that you're trying to do. Okay, so let's start with scenario number one. So 30 years ago in a galaxy far, far away, I was the transfusion medicine fellow covering the transfusion service. At 6 a.m., I got a phone call from the on-call resident informing me that an ICU patient had received a unit of A negative blood. Patient's blood type was O positive. Not good. My initial response was, oh my God, stop the transfusion. My next response was, I think you better call the service and get them to the bedside to provide supported care as needed and initiate a transfusion reaction workup. So this kind of illustrates to you when you see that when there is the potential for acute hemolytic transfusion reaction, time is of the essence. How much incompatible blood a patient gets is related to how severe their reaction may be. And you want to stop the transfusion immediately and then basically take care of the patient. And care of the patient is, of course, the most important thing. And you have to involve the primary service in order to do that. Unfortunately, in this situation, the patient was critically ill at the time and did not survive. It was difficult to determine which morbidity caused the problem, but it was highly likely that the incompatible blood transfusion accelerate the process. What a way to start a day. Luckily, I don't have very many of these. This is a sort of one in a million, one in even less than that. But it did happen. So this was actually a real case. So let's start with the basics. How often does this happen? Well, it was interesting to sort of understand that blood transfusion is actually the most common therapeutic procedure performed in hospitalized patients. This data from 2019, 15% of inpatients are transfused during their stay. Serious adverse reactions occur in 1%, and up to 5% of these serious adverse reactions are hemolytic. There's a lot of other things that can happen as the result of a blood transfusion, and that are a reaction. We can have anaphylaxis, we can have sepsis, a lot of different things. But we all are, our worst nightmare is an acute hemolytic transfusion reaction because it has the potential to be fatal. And we kind of teach everybody that it is fatal. The issue is that it can be, it isn't always. And so there are things you can do to help a patient get through it. So what is that? So transfusion-related fatalities have to be reported to the Food and Drug Administration. And this is some data. It's kind of old, but then that's as good as we get from the government at this time. And it shows you sort of over time, what are these fatalities sort of due to? And if you look at the sort of bottom of the graph, this is the fiscal years, and this dark blue represents ABO incompatible transfusions as the cause of the fatality. And you can see it's sort of consistent. It's low amounts, but every year, at least every fiscal year for this period, there was at least some ABO incompatible transfusions, and these particular ones were fatal. So let's do a refresher on the basics of ABO blood types. So remember, there are 4 different blood types. There's blood type O, and when you are an O, you don't have any of either the A or B antigens on your cells, but you have anti-A and anti-B in your serum, and so, or in your plasma. So you can, this is what we call sort of the universal donor. You can give type O blood to a lot of different people with different blood types because they don't have any of those antigens present. If you're a type A, you have A on your red cells and you have anti-B circulating in your system. If you're a type B, you have B on your red cells and you have anti-A circulating in your plasma. And if you're AB, you have both of those antigens present on your red cells, and you don't have either anti-A or anti-B. So this is a chart that gives you an idea of the compatibility, who can receive what. So O's can basically receive O's, and they can't receive A or B or AB units because the antibodies that they have will react with the cells that are transfused. And so you can see from this chart, again, you have more options with, you have another options with A and B, and you have you have a lot more options as well with ABs. So again, we kind of think of type O as sort of the universal donor, because you can pretty much give type O if you're only looking at ABO antigens to everyone. But if you're AB positive, basically you're what we would call a universal recipient, because you don't have the antibodies, and you can get different kinds of units, and you won't have a reaction, or at least an immunological reaction. So that gives you a sense of sort of what's available. And so you can see for some blood types, there's lots of choices that you have, and for some blood types, there aren't very many. And so again, that's the challenge of being a blood bank and trying to sort of have the right kind of supplies available, is you have to think about sort of how common these are in the population, and is that reflected in your sort of units that you have on hand. So why is ABO incompatibility so dangerous? Well, the issue is that those anti-A and anti-B antibodies are pentameters, or and it's the best I can say it, and they can kind of react with when they see cells, red cells that have the antigen that these antibodies are directed toward, they will bind to those red cells. And the thing is that these red cells kind of get clumped, excuse me, let's go back. And they can and then when this happens, they will activate complement. And complement then is really responsible and as the complement cascade proceeds, it results in lysis of the red cells and release of the contents of the red cells into the circulation. As a result of that, you can see circulating free hemoglobin, which is toxic to the kidneys. You can see activation of neutrophils, which can have an impact on the lungs. You can see activation of macrophages. And so all of those things can lead to, depending on how much of the incompatible blood you got and your sort of underlying condition, can really sort of have a huge impact. It can certainly cause death. It can also cause severe illness that you can recover from. You know, not every ABO incompatible transfusion is lethal, but they sure can be. So you have to get on it right away. So what are the signs and symptoms of acute hemolytic transfusion reactions? Well, you know, often when you have a reaction, you get symptoms pretty quickly. A lot of them are chills and fever. They can have a low blood pressure. They can develop uncontrollable bleeding like DIC. They can have tachycardia. They can have pain in various areas. You might see red urine as a result and poor urine output, an elevated bilirubin, and red or pink plasma when you spin down a sample and take a look at that sort of plasma. So those are the signs and symptoms. And again, people usually react fairly quickly to an ABO incompatible transfusion. The management immediately is to stop the transfusion, provide supportive care, and to initiate a transfusion reaction investigation. So stopping the transfusion is really about limiting sort of the amount of incompatible blood given. And, you know, basically you can't really do anything about sort of what has the incompatible blood that's already in the patient. So you have to provide supportive care for the signs and symptoms that are occurring, and you have to figure out what happened and what's next. So we go back to our scenario. You know, what happened in this particular case? Well, blood was ordered for the ICU patient. It was near the end of the night shift, and the blood was sent using the pneumatic tube system. So upon arrival, the two nurses checked the unit. It's not clear exactly sort of what they checked. They kind of went back and forth. And then only one patient had an order for transfusion at the time, and the transfusion was begun, but they didn't check the unit with the patient's wristband, the patient's identity. And the problem turned out to be that the unit had been sent to the wrong ICU, and recipient identification at the bedside was not performed. So there was a lot of checking, but not checking of the right thing. And most importantly, you know, is this the unit for this patient? And sometimes we get, you know, sort of lost in the, you know, checking this and sort of checking that. But the most important thing of all is always checking patient identity. And it is, when we see ABO incompatible transfusions, it's the most common element involved, is that lack of patient identification. So That's one. That's kind of the extreme example of, ABO incompatibility. So here's scenario number 2. The type and screen was ordered for an oncology patient for transfusion that afternoon. The phlebotomist went to collect the specimen. Now, although the order was for Carl A. Anderson, the specimen was collected from Carl R. Anderson, who was on the same floor. The phlebotomist selected the ID label from her stack of pre-printed ones, did not detect the error during her visual verification, and sent the specimen to the blood bank. The lab, fortunately, detected the error when the patient's blood type did not match the previous type. And in this case, an acute hemolytic transfusion reaction was avoided. So, again, this is a sort of an example of that, again, patient identification, making sure you have the right patient. And it's the reason for having sort of two identifiers when you're checking patient sort of identity. And what that means is that you look at something like name and birth date, that you use name and medical record number, that you use 2 independent identifiers that are associated with that particular patient. It doesn't mean that 2 people have to do it. What it means is that you have to have 2 independent pieces of information or pieces of sort of identification that tell you that this patient is that patient and they're the same. And so it's really important, again, from that perspective, to, again, use the wristband, which has information as part of you can use multiple things on the wristband, but you have to be able to sort of identify the patient in that way. So what can we do to prevent these? Well, so I went to the ABB requirements and said, what do they require? So they require that the order has to come from a physician or other authorized allied health professional. They have that the identifying information has to correspond and be confirmed at the time of collection, again, using 2 independent identifiers. And those could be name and date of birth, name and medical record number if unique to that patient, name and social security number, and often, again, using the information that is on the patient's wristband. So it also says there shall be a mechanism to identify the date and time of sample collection and the individuals who collected the sample from the patient. And I highlighted mechanism because it basically, gives you some, options in doing that, and how you sort of say who that is. You have to have it. It has to be, we use initials as well to sort of identify on the label itself who was the collector, but most of our sort of information is in our information system. And so we can sort of verify things in looking at that as well. And the completed label shall be affixed to the sample container before the person who obtained the sample leaves the side of the patient. Now, inpatient versus outpatient. Inpatient actually, in my mind, is sort of easier a bit or safer or whatever you want to call it, because someone has identified that patient at the beginning at admission and put a wristband on their patient. So you have something attached to the patient who identifies who they are. In the outpatient setting, that's not the case. Again, you have a patient who might have a piece of paper with them, CSN or whatever you call it, or an order that you have, but there is nothing physically on the patient necessarily to sort of say this is who that patient is. So it's a little harder on the outpatient side to do that. We do see mis-IDs in an outpatient setting, and it's often because the wrong patient responds to the call to come into the phlebotomy room. And so again, we have to have mechanisms at the time with the patient to sort of, again, try to make sure that you have the right patient. But that can be a challenge too. We do see mis-IDs on the inpatient, in the outpatient setting. So there's also requirements from AABB for pre-transfusion testing for transfusion. And essentially it says that there shall be 2 determinations of the recipient's ABO group. The first determination shall be performed on a current sample. The second determination can be done, you can use it by comparing to previous records. So if the patient has had a blood type done in your facility and the 2 match, then you're good. Testing a second sample collected at a time different from the first sample, including a new verification of patient identification. So if you've never seen the patient before, this is the first time you're planning on transfusion, you will need to get another sample independently, and so that the 2 blood types will match. And if you use an electronic identification system at the time of sample collection, so that you know for sure that the blood in the tube is the blood in that patient, you can type that same sample again to verify that it is that it is the correct blood type. So those are the kind of the options. This is relatively recent, having this 2 samples, but again, it's really a safety measure in terms of trying to make sure that, again, you have the right patient and the right blood type. And that you do see, as in what I talked about, that there can be times when that has been different, and it can use that second to sort of say, okay, so this isn't the same person. What went wrong? And then you have to start investigating. The transfusion service shall accept only those samples that are completely, accurately, and legibly labeled. And the transfusion service shall have a policy to reduce the risk of misidentification of patient pre-transfusion samples. Now, potential policies are what very commonly people do as a means to do this is have blood transfusion armbands. So type an X or whatever whatever it is, you are using basically another second means of identification sort of for that patient and decrease the risk of a misidentification. So that's something that's relatively common. You can see a lot of those in many places. There could be other policies. So we have a different approach, which I'm going to illustrate for you, where we have a kind of closed loop system to generate samples for transfusion for phlebotomists. And we don't use a specific transfusion armband, but again, it's very commonly done. So armbands, just to kind of give you a sense, there's all kinds of them. And, it's interesting. Here's one where you actually have the patient's picture on the armband. I don't think that's necessarily common, but, they can have a lot of different armbands at the time. And so again, you need to make sure that the one that you need is the correct one. But again, I think a lot of these, there's also for most of these blood bands, that there's an identifier on on that band as well. And so you have another thing to check to make sure that this is the right patient you're going to give that blood to. Now, sample label creation, there's kind of 2 approaches to this. One is, again, you pre-print the labels in the lab and, go out, and the phlebotomist goes out with the labels and the like, and then does their rounds and collects the samples that they need to. But there are also ways to sort of look at it, printing the labels at the bedside after scanning the patient wristband. Now, I remember when I was a resident, this has been a long-standing issue. When I was a resident, they decided to put these armbands on patients that had a little plastic card, and you had to use this gun to basically create a label from the card on the patient's wrist. Well, it's a good idea, but the residents, what they would do would essentially print up a bunch of those labels and then put them in their pocket for use later on, which it kind of defeats the purpose of what you were trying to do. So you can't underestimate, how people will sort of work with the systems that you have, because again, everyone is trying to do the right thing, but they're also trying to be as efficient as possible. And so, if they don't recognize the risks, or if they're in a hurry, you can see shortcuts being made. That will be problematic. So I have been an advocate of printing, labels at the bedside for at least a couple of decades. And, it's not necessarily an easy thing to do, but we have at Mayo developed a way to do that. And that's what I'm going to show you. And then I'll show you what the results of that are in terms of sample errors. So again, what are the other requirements? Transfusion service shall confirm all identifying information in the request is in agreement with the sample label. And if there's any doubt, get a new sample. Patient samples and segments from any component that has been administered are kept for at least 7 days after transfusion. And pre-transfusion tests for allogeneic transfusion shall include ABL group, RH type, and pre-transfusion testing for unexpected antibodies to red cell antigens for those that have red blood cells in them. So those are the requirements for pre-transfusion testing. And you have to get a new sample every 3 days or within 3 days prior to transfusion. And particularly if the patient has been transfused in the preceding 3 months with blood or blood components, the patient's been pregnant, or if the history is uncertain or unavailable, and day 0 is the day of the draw. So this is, and the reason for this, why do we care that there's the 3-day limits? Because patients who have antibodies, red cell antibodies, can lose those antibodies over time. And so they can disappear and you won't detect them in your pre-transfusion testing. But if you give them antigen positive blood to those patients, their red cell antibody may come roaring back. They'll often and potentially cause either acute or delayed hemolysis. So we have that 72-hour time frame so that we don't that we catch anything that might happen as a result of previous transfusion. The same is true for a woman who has been pregnant in the preceding 3 months. So again, because their antibody, they may have an antibody, it may have gone to a level that's undetected, but again can come back with transfusion. And in certain circumstances, you can collect pre-transfusion samples up to 28 days prior transfusion if there's no history of transfusion. And it's often, and we use this often for surgical patients. So you get a patient and they decide to do surgery and there's a data scheduled. And, then they come in the morning of surgery. AM admits are very common these days. And you got to do a transfusion you have to do a type and screen. And if there's a complicated issue that you have to deal with, and multiple antibodies and warm auto, things like that, that could delay the start of surgery for that particular patient. You're trying to figure that out. And if you can do it ahead of time and it still be valid for use in transfusion, that's a better approach. So again, there have been rules sort of put together recognizing that, there are potential for delays, and this is how we can avoid them. That's in compliance with the AABB standards. So let's talk about Mayo Clinic. And I show you kind of what we deal with. So this is we have inpatient phlebotomy, and this is our volumes. So you can see that in October of 2021, we did 40,739 blood collections. That's huge. And we have a staff of phlebotomists that's 144 FTEs in order to deal with our large hospital and provide the services for all the patients and the providers in a timely fashion. So this is a huge volume, and it is how can we make it so that it's as efficient as possible, but safe. And that's the challenge. So we've sort of developed an approach to for a phlebotomist to basically be sort of self-sufficient on the floor and basically do collections that they need with a cart. So this is our phlebotomy cart, and each phlebotomist has one. And there is everything that you need for specimen collection out on the floors and in the emergency department is on this cart. And I'll show you sort of the pieces. Now, this cart isn't sort of I was an advocate for doing something like this. This is not my idea. I am sort of sharing with you what our quality specialists and others in phlebotomy designed and put together in order to make this what we call a closed loop system. And I'll sort of show you that as we sort of go along. So this is our phlebotomy cart, and we use it all the time. So here are what we do is essentially, when we go to collect blood from a patient, the first thing we do is scan the wristband for patient identification. That starts the process. You can't even start the process. You can't even do anything on the computer on this cart unless you have unless you've scanned the wristband. And at the end, and you can't finish the collection until you've scanned the wristband at the very end. So this is very controlled. There's a lot of sort of help from the computer and sort of the applications that allow you to do this. These are the labels that are essentially generated, and they show you a variety of things. This is what the test has been ordered. This says that it's routine. So there's a lot of different information on this that can be helpful for the phlebotomist and for troubleshooting sort of down the way. So this is what gets generated from that. And then this is what's on the cart. So the cart has a screen. It has basically a keyboard, a mouse, and a barcode scanner. It has a computer that's within the cart that can basically run the laboratory information system sort of on a wireless connection. We have a Sharps container, and this is the battery. So these things are charged when they're in use. When they come back to the phlebotomy area, they're connected to electricity and charged so that they're always ready and available for someone to take and go collect a specimen. So let's see here. All right. In the top drawer, this is the top drawer of this cart, Tuborama. So we have all kinds of different tube types, so they can collect pretty much anything on almost anything on the menu. These are some syringes, and both sort of 10 ml syringes and 3 ml heparin syringes. This is the bottom drawer. So again, we have different sizes of needles, basically a gauze for once the phlebotomy is completed, a variety of, again, syringes and different kinds of adapters and the like. So have that. Then there's a trunk on the cart that has basically blood culture bottles and a set, and then a variety of syringes and some swabs. And then when you look at the bin above the trunk is where the bio bags are, micro tube sleeves, clear vacutainer attachments, again, a variety of things. Everything you need, even heel warmers for essentially neonatal collections or pediatric collections. And it also has a label printer. So you can print the labels that you've done, that you've scanned from the barcode that you scanned on the patient's wristband. And we also have gloves, hand sanitizer, and I think this is our sort of our decontamination sort of solution that we use to kind of clean off between patients. Here's the computer kind of hiding underneath it all. And it is ergonomically adjustable. So this is me. I didn't realize I had my sunglasses on. I'm not trying to be a gangster, but it shows you essentially how these are adjustable ergonomically. So this is the shortest it can be, and this is the tallest it can be. And clearly I couldn't use this particular cart. So you really have to have this adjustment base available because people are of different heights and need the different things. And then when the collections are completed, we can use there's a hospital pneumatic tube system. So if we have to send something to someone somewhere else in the hospital, we can do that. But we also have a campus tube system, and that is where we can send samples and the like downtown for analysis. So we use both tube systems. There's one folklore in that with the campus tube system. There's a tube that fell into the blood bank one day, and when we looked at it, it had a unit of blood in it, and it was from the year before. Who knows where it was for how long, but it was that's kind of the folklore that we have sort of in transfusion medicine related to that. Now, we also use the carts in the ED. So one of the things we've sort of learned is that, how can we do as much as we can with a patient before they can get into a room in the ED? So we've set up this phlebotomy station in the ED. So again, you have a chair, you have our cart that has everything you need. And so often they'll do a sort of what they do with the ED patients is they do a sort of a simple kind of intake process. The doc will take a look, and if they decide that they want specimens for analysis, then they tell us, and we do that while the patient's waiting in the lobby, not necessarily waiting for them to get inside. And then often once you get to your room, then sometimes the test results are available at that point in time. So again, we've tried to sort of try not to make the waiting time totally wasted, is trying to use it as much as we can to sort of process things so that we have now in our ED sort of boards that tell how many patients have been seen and how long the wait is. So people will know sort of what they're facing. So this thing is really a closed loop system. Everything is done by only one patient done for only one patient by only one phlebotomist. And because it's closed loop like this, there's a significantly decreased risk of misidentification if used according to, again, the standard operating procedure. And this is data on outpatient misidentifications. And you can see they're scattered, but they do happen periodically. This is this is sigma. You want to be at 6 sigma, and we are for the most part, but we still see sort of mis-IDs on the outpatient side. This is our inpatient misidentification since we implemented the closed loop system with the phlebotomy cart. We haven't had one since May of 2018. This is amazing from my perspective, because I look at the hospital as the hardest area to sort of do this. And yet by using this particular system with all its checks and balances and done by just a single person really makes a difference here in the risk of a mistake and an ABO incompatible transfusion. So one of the other things that I want to make sure we talk about a little bit is the sort of error prevention and process control. You know, there's a lot of ways to sort of do things, and you want to, and if you've got a problem that you're trying to solve with the process, you want to do something that's going to solve the problem and not necessarily make it worse or not have any effect at all. So there are strong and there are weak interventions. You know, the best thing you want to do, the best thing you can do is to make the right thing to do the only thing you can do. And that often requires a hard stop, or it forces you to do something. And that's fine, except when you need to make a variation. And then you've only complicated the problem. But generally, you want to make the right thing to do, if you can, the only thing to do. You can also make the right thing to do the easy thing to do. And that is, you know, again, laying out a process that's easy to follow. It has a smooth and easy workflow and isn't that much different from the reality of the day. It sort of fits in. And this is sort of what I really try to do most often, is making the right thing to do the easy thing to do. But it's a challenge from the process perspective. You also can take the approach of removing distractions. So nursing will often sort of, when they're doing dispensing of medications, will go into a quiet room and close the door and do their work and then come out so that they don't get interrupted and they don't make a mistake. You can also have someone else double check your work because someone else may catch your error. You can double check your own work, so you may catch your own mistake. But the approach that you should take in terms of how strong your intervention be should really reflect the likelihood and the clinical impact of the error. So the more serious it is, the more you should try to develop a good process to make the right thing to do, either the only thing to do or the easy thing to do. So I always use sort of blood infusion sort of bags as a way to kind of illustrate this. Is like, you know, a lot of these look alike. Would you recognize which one you need if you were, because these are not the same ones, lactated ringers. That blue printing isn't very easy to see. That sodium chloride looks pretty good, and that dextrose looks pretty good, but some of that writing is pretty small. And so again, it's like, how can we use, so the idea is, when you got a challenge like this, how can you use technology to sort of help you? And unfortunately, with IV bags like this, you know, the best thing in my mind would be barcode scanning, but we haven't really figured out a way to do that. And so that's a challenge sort of for us. And so again, you need to figure out where your weak points are and what you can do to sort of work around them. So, you know, process design and process control is really a balance of how do you, you know, documenting compliance is a must, but workflow is the key. And sometimes they're in opposition, as shown by the boxers, because sometimes what's best for the process isn't best for the workflow. And so you often have to come to, compromises or change designs or the like. We have an electronic medical record. We update it and sort of modify it on a regular basis to, again, fine tune the workflow in order to make the providers as efficient as possible. So there's this concept of people, process, and technology, and they really have to come together in order to sort of make the right things happen. And with people, you have to sort of have the right culture. People want to do it. You have to have the right technology that actually is helpful, and you have to have the right process, which makes it makes it easier to do. So I think the challenge is it's hard to sort of maximize all of these at the same time. And so trying to find that sweet spot in the center is a challenge. And I think it's something you have to sort of do and look at all the time, because there's always changes that happen. Other innovations that can improve your operations, we now have what's called the electronic cross-match, or what they call a computer-assisted cross-match. If a patient sample meets certain criteria, you don't need to do a serologic cross-match, which may take a significant amount of time. A computer can be used to verify ABO/RH compatibility if the patient doesn't have clinically significant antibodies, either existing or in the past, if you've got a computer system that's FDA cleared for that function, and you must have evidence that at least 2 blood typing tests have been performed and give identical results and no ABO discrepancy. This can facilitate remote dispensing of blood units for transfusion. We use this in the ED, in the OR, medical transport. Again, if you've got to, we actually, at one point in time, I don't know if we still had a hemo bank in the OR where people could go get, for certain patients, ABO compatible blood to bring back to the OR and transfuse. And so, again, looking at those options, how can they help sort of provide in certain circumstances? Other things that are coming up are basically massive transfusion protocols. Everybody's really developing these for mostly trauma, but they can be used in other massive transfusion situations. And the problem with massive transfusion is that patients who get a lot of blood, they develop sort of this syndrome of refractory hemorrhage, basically because you've diluted out their clotting factors, they're cold, and it's hard to get them warm. And when you're cold, your coagulation cascade doesn't work as well. You can end up, if you get a lot of units, you can end up with some hypocalcemia because of all the citrate in the blood that's being given. And acidosis. Patients who are acidotic don't have as good function either. So what people have come up with is these protocolized, balanced transfusions of different blood components. And the table on the right kind of gives you a sense of, so they kind of do it in rounds. So they declare a massive transfusion protocol. The blood bank then knows how much blood to give them. They will have worked that out ahead of time. It's a protocol. So they'll send all those units. And then the first round of transfusion, the patient will get 6 red cells, 6 FFP, 6 platelets, and 10 units of cryo. Then if they need to kind of continue transfusing, they do round 2. Then again, in this example, round 3, they use tranexamic acid, which should help with platelet function. And you can see. So, and this is the nice thing, is that you kind of declare that. And then the blood bank gets sort of in place and sends product. They know they're going to have to send product at various time points. So again, it just becomes more routine and automatic. So with that, you know, actually, I do want to tell you a story about in the early days of liver transplant. I'm old enough to have been around at the time. In the early 90s, when we had a liver transplant, we would basically prepare 30 units of red cells, 30 units of FFP, 30 units of cryo, and 30 units of platelets, and make sure it was all in the location where the transplant was going to happen. And sometimes we went through all of that. So today we're not nearly at that. I think in my mind, trauma has become sort of more of the sort of underlying reason for massive transfusions. But again, that is what we do. And that was an MTP way long ago. There's always that, you know, elimination of blood sample collection errors is possible, but it's not easy. And the biggest problem with process change is the impact on workflow. And you've really got to find the right balance for that. You know, we always talk about, should the practice needs drive the process development? Well, yes. Should the process needs drive the practice? Well, yeah, it's both. It becomes a sort of compromise and design. What would work best in your situation for the process and its impact on the workflow of folks. People who are frustrated with the workflow are not very happy campers. And so, you know, I think it's really important to be aware of that. So with that, I have completed my presentation and open for questions.
Thank you, Dr. Sandtrack. At this time, we would like to take any questions that you may have. You may submit your questions through the Q&A icon in Zoom.
So there's a question. With staffing shortages in phlebotomy, we are evaluating having nursing staff draw blood bank samples and banding. Do you have any thoughts on this? So I'm not against it. I think, again, will they do it often? I think the biggest challenge is, will they do it often enough to be good at it? And will you have kind of minimum, you don't want to create a whole lot of errors. And you don't want to take, and again, depending on where you are, can you afford to take a nurse away from, you know, other cares that they're giving to do that? I don't know that there's a right answer sort of either way. I think you have to figure out what you're trying to balance and sort of where the least sort of problems will be with that. Nurses are capable of doing it, but it's a different skill set than they're used to doing. And it's not necessarily direct patient care. Okay, I just did not stop one thing. Hold on a minute. Sorry about that. Okay, we're done. All right, so again, it's all about workflow and how you manage that. So I would say the best thing you can, you know, you just have to kind of figure out if that's the right approach that you want to take. You could do either way. It's just what's going to work best for your facility. Okay. And the next question is, are you looking at any other identification processes, fingerprint or optic? That's a good question. I don't know that we have, but I wouldn't be surprised if we will. And so I think it's a matter of time. We do a lot of we have badges that open up things and do a lot of things for us. We haven't kind of got into like going to the airport and using Clear where you have your eyeball scanned. But I think those are potentials in the future. You know, how do you make sure that the person that you're going to do something to is the right person? And, you know, wristbands are great, but they're not infallible. And so I wouldn't be surprised if at some point in time we do something different, but it's not there yet. And again, could be beneficial in op areas, nursing homes, I agree. So I think it's just a matter of, the technology. I think there's also, a lot of people have concerns these days about privacy. And, what are you going to do with my eyeball scan? And, what is that going to mean? And so I think there's a lot of, if you're thinking about moving into high technology, you have to think about what the patient reaction might be and how you're going to mitigate that or manage that. And so, one of the things, I'll share a story with you. In our emergency department, we have cameras everywhere. And they're mostly to look at flow. And actually, we do, studies of different staffing models and the like in the ED and use those cameras to sort of see how things are flowing. But, at the beginning, it was like, what are you filming? What are you going to do with that? And so you have to be able to answer those questions, and you have to be able to sort of open, be able to sort of explain things and reassure patients that their privacy isn't being invaded. That to me is one of the things that you have to be aware of. So the next question is, what does the future hold for the use of artificial blood? I think that this is, it's something we need. It's a hard thing. And we don't really have anything. There is one solution that's available for compassionate use, but there's no commercially available solution. The challenge with artificial blood is that, again, it is derived for the most part from, it's not really artificial, it's sort of free hemoglobin that they've manufactured mostly from human blood, but it has side effects. Again, free hemoglobin itself is toxic to kidneys. And so there's been issues with that. There's been issues with reactions. There have been some studies where they have used it in trauma situations, actually out in the community. We had a trial like that. But again, there hasn't been enough good data to show that it's safe and useful. I expect one day that will come. I think there's actually, artificial blood for animals like dogs, but there isn't for humans. And that's the kidneys are the primary issue. Hypertension is also something that you can see. So it's really been a challenge to sort of find something like that. I think it will come eventually, but I've been saying that for 30 years. So it still hasn't happened. And I've been involved in some of the trials. One of the big issues with the free hemoglobin solutions is that they are colored, and you can't do a lot of lab tests after you've administered those. And so that becomes also a disadvantage, is that if you can't monitor some of the parameters for your patient that are measured using colorimetric methods, that's a problem, and you could be missing something. So we'll see. I think it's not a slam dunk.
Thanks again, Dr. Sandtrack, and thank you all for participating in today's phlebotomy webinar. If your question was not addressed during today's session, or if you have any additional questions, please include them on the evaluation that will be sent to you tomorrow from Zoom. Laboratory credit is extended for this program. Upon finalizing your evaluation, you will have the option to claim credit and print your certificate. If you had registered for this webinar and joined by phone only, please email us at mcleducation@mayo.edu if you do not receive the evaluation. As a reminder, this program was recorded and will be archived on our website in a few weeks. Thank you again for joining us for today's webinar.